Illinois, and the clinical professor of surgery and anesthesia at UIC. As a young medical student, Dr. Candido realized that he wanted to relieve the pain and suffering of his patients. And he's exceeded that desire by becoming an international leader in the diagnosis and treatment of all painful conditions. He educates pain management physicians and providers all over the world. His research and written work on the treatment of pain fills volumes. In addition, he's also trained residents and fellows who now practice all over the United States. And SCPM is very fortunate to have Dr. Candido as a regular educator at our courses. So today he's lecturing on the topic of the best practices for prescribing opioids and controlled substances in 2023. As you're all aware, the opioid crisis continues to be a daily headline in both the medical and the media news. So the importance of physicians following the guidelines is more important today than it ever has been in the practice of medicine. I'm very pleased that Dr. Candido has agreed to tackle this tough topic. So I'll turn it over to Dr. Candido. So now, Dr. Candido, if you can pull up your PowerPoint presentation.
Can you see it?
Yes, I can see it and I can hear you.
Thank you, Kathy, for that introduction. Thank you to all the attendees. It's a privilege to once again participate in the Society for Pain Practice Management, where I've got a long history dating back almost 20 years with this great society. And as Kathy pointed out, today we're going to discuss prescribing opioids and controlled substances, the best practices in 2023. Know the guidelines to prescribe appropriately. And that's an interesting topic to me. I've had a fascination with the opioid epidemic and crisis, and I've lectured extensively about the origins as well as some possible remedies for this continuing public health crisis, which primarily affects the United States of America, but which is also a worldwide phenomenon. And it's interesting to me as well that recently in November, in particular November 4th of 2022, so about 2 months ago, the Center for Disease Control in Atlanta, Georgia, came up with new guidelines to supplant the previously well-known guidelines from 2016. So today we're going to discuss very briefly the former guidelines and then go over the 12 steps in association with the updated guidelines for 2022 for the appropriate prescribing of opioids and controlled substances. And I have no disclosures as they relate to this educational activity. See if I can change my slide now. Okay, let me see. Okay, and the next slide. Let's see. Kathy, my control button is not allowing me to proceed to the next slide. Let's see. Okay.
If you want, I can pull the slides up, and
sure.
You can tell me when you.
Here, did I do that, or did you do that right there? Anyway, so we're on the next slide. Okay. Now.
Okay. Yes, I can see your next slide.
Great. So, as physicians, as clinicians, as nurse practitioners, as people who manage pain, we were lambasted about a decade ago for prescription drugs as being felt to be at the epicenter for the opioid epidemic, and people paid great prices and consequences for the practice of prescribing opioids. A lot of physicians had sanctions placed upon their practices. Many people went to jail, lost their medical licenses, DEA licenses, and so forth. We were blamed for being spearheading the opioid epidemic, but clearly the real culprit is not physician practices by and large. The real culprit is synthetic fentanyl, which has killed more Americans than any other drug combined, and is really something of a, not just a public health crisis, it's a world health crisis. And in fact, not only has the opioid epidemic and the use of fentanyl in this country been associated with horrible consequences, loss of careers, loss of jobs, loss of lives, both for patients as well as care providers. Fentanyl use has been associated with a reduction for the first time in 25 years in life expectancy for adults in the United States of America. We're down to 76.4 years. It's the lowest point in the life expectancy of Americans in the last quarter century. And that's actually not just a consequence of fentanyl, but also COVID, of course, plays a role. But fentanyl is felt to be the #1 cause for the reduction in life expectancy of Americans. And if that doesn't capture your attention, I think nothing else will indicate to you the seriousness of the current opioid epidemic. And in 2021, in the United States, we surpassed a staggering milestone. There were more than 100,000 drug overdoses in a 12-month period. Now that includes not just fentanyl, it also includes prescription drugs, street drugs like heroin, cocaine, benzodiazepines, and so forth. But it was the first time we had gone beyond about 70,000 deaths in this country. And that number has persisted into the year 2022. So we've first hit the 100,000 loss of lives milestone in 2021. And we actually, when statistics were reanalyzed, it was about 106,000. And then again in 2022, we stayed at about a flat level of 107,000 deaths. And if you look at this statistic, it also shows a 28.5% spike from the 78,000 deaths in 2020. That was when we analyzed the 2021 data. And Vermont had a 70% rise in deaths. West Virginia, Kentucky were also high at 62 and 54.5%, and New York State saw a 20.4% hike. But this was a nationwide phenomenon. It was seen across the entire country with a spike in deaths, overdose-related deaths, not from prescription narcotics of physicians, but it does influence how we think. It does influence how we make selections for our patients, but also and primarily based upon illegal fentanyl, which is produced in countries like China, Mexico, and India, and which is transported into the United States through Canada and Mexico primarily. So you can look at the overdose deaths in 2020, there were 78,000. The following 12 months into 2021, there were actually an adjustment to 106,000. You can see the states that were up: Vermont 70%, Kentucky 55%, Tennessee 50%, West Virginia 62%, Louisiana 52%, and as I stated, New York State was at 20.4%. But all states were affected. This is a global and national phenomenon. And in the year 2022, we had about 107,000 overdose-related deaths. The DEA announced that last year in 2022, they had confiscated 50.6 million fentanyl-laced counterfeit pills. It was enough fentanyl to kill the entire United States population. But think about it, folks. If that's what the DEA has confiscated, that probably represents a very small fraction of the amount of fentanyl which is actually permeating our country, streaming across the Canadian and Mexican borders and getting access to ourselves and to our children. And there's a wealth of evidence now indicating innumerable deaths in high school students, grammar school students who are exposed to fentanyl. So the DEA seized 50.6 million counterfeit pills, but that doesn't mean that that's what was in the country. There's probably 10 or 100-fold the number of fentanyl pills. Fentanyl is often made to look like real prescription drugs, including Xanax and OxyContin, and that's how it's manufactured in these pill mills. We have them in Texas, we have them in Arizona, we have them in California, where the powder is reconstituted into pill form and then is distributed far and wide across our entire nation. If you see here, this is how some people smuggle fentanyl into the country. Here's an individual arrested for smuggling 91,000 fentanyl pills inside potato chip containers. In Mexico, they fill coconuts with massive quantities of fentanyl tablets and try to transport it through legitimate business enterprises into the country. They're actually getting very clever in disguising fentanyl as Nerds, Skittles, all kinds of candy products, and trying to legitimize the transportation, the dispensation, and the vending of these products to our American population. Now, another consequence, of course, of fentanyl is that even inhaling fentanyl can be lethal in very small quantities. I take you back to a siege that occurred in Moscow some 20 years ago, where Chechen rebels got access to a theater and held hostages, and the Spetsnaz organization, which is kind of a hybrid between our FBI and organized crime, if you will, actually contacted Dr. Theodore Stanley at the University of Utah about how to liberate the hostages from the theater. And Ted Stanley indicated that you could put fentanyl or carfentanil into a ventilation system to anesthetize everyone in the theater. But of course, the Russians utilized a much greater concentration than had been recommended, and many theater goers were killed while the rebels largely escaped. But fentanyl, here you see a paper where New Jersey police officers who came to bust a fentanyl ring in that state got very sick just by being in proximity to individuals who were manufacturing and distributing fentanyl, just by breathing without having the appropriate gas mask, respiratory apparatus, and several of them were hospitalized in critical care and critical condition. So fentanyl is extraordinarily toxic. We have enough fentanyl in this country to kill every man, woman, and child many times over. It's becoming more accessible to kids on social media, and many case reports now indicate that otherwise children engaging in a common practice of smoking marijuana, or what they believe to be relatively a popular topic and popular event, is now being associated at an alarming rate with deaths from overdose, because a lot of the people out there are mixing commonly found drugs on the street with fentanyl, killing a ridiculous number of American kids. Kids are using fentanyl in vape pens. There are kids who are passing out in schools. There are teachers who are vaping and passing out in schools. It's a national and international health crisis, unlike anything we've ever seen. Here's another article from last year. Connecticut officials warned of fentanyl-laced marijuana. Dozens of overdose deaths, including children as young as the age of 13 and 14 dying from smoking, taking a couple of puffs on a marijuana cigarette. Authorities seized 1.7 million fentanyl pills in Arizona in a single day. That's an incredible number. That number of fentanyl pills could kill everyone in the state of Arizona. And here's a paper just from a few days ago, January 5th of 2023. 70 million lethal doses of fentanyl were seized in the state of New York last year. Again, enough to kill a vast percentage of American citizens. And how do we get this? Well, how does it come across our borders? Interestingly enough, and sadly enough, even otherwise legitimate practitioners, here's an article which shows that flight attendants are being recruited as mules because they're obviously seeking to augment their salaries, which is quite good by and large. And they're carrying, because they have lax restrictions through security lines, they are able to bring things across that otherwise normal passengers, pedestrian passengers, would be stopped through the security screening process. And there are now several case reports of flight attendants being stopped, having their belongings confiscated, and then looking at long-term jail terms for bringing fentanyl using legitimate commercial airlines into this country, largely, as I stated, through the countries of Canada and Mexico, but also from the pill mill areas of Arizona, from Texas, and from California by and large to other states. So it's not just an international issue, it's also a national domestic issue. You can see that the primary movers of fentanyl across our borders are the Jalisco and Sinaloa cartels. There's been a lot in the news about that. And you can see that that corresponds to the fact that our government not only is having a trouble at the borders, where we have a lax security at the borders, and this allows a great influx of these drugs, but also on the same screen you can see that the government now is trying to penalize not just clinicians, not just cartels, but also the pharmaceutical industry. It seems that everybody has to be punished for the opioid epidemic. And this is an interesting paper that was just in the lay press in November of 2022. You'll see that Walmart, Walgreens, CVS are paying $13.8 billion, which would end thousands of lawsuits filed against the pharmaceutical companies for filling prescriptions that they should have flagged as inappropriate. Remember, the pharmaceutical industry has been deemed to be complicit along with the manufacturers of controlled substances, as well as physicians, as well as nurses, as well as clinicians who are otherwise well-intentioned trying to manage pain. All this information is interesting, but it also plays into why the CDC changed their recommendations in 2022, and we'll talk about that. So the first guidelines that were promoted, and many of you are familiar with this because they were really draconian and restrictive in some regards. It was a CDC guidelines in 2016, which was intended for primary care physicians. Now, why was it intended for primary care physicians who were treating chronic pain? And that was defined as pain which had a 3-month or longer duration. And it excluded things like cancer-related treatment, end-of-life treatment, palliative care, etc., and pediatric type pain. The rationale was that primary care physicians manage a lot of pain, but they have very little training in the management of pain. And by and large, we know that that still remains true. 37% of the prescriptions written for controlled substances are written by primary care physicians. A much smaller percentage are written by orthopedic surgeons, are written by interventional pain physicians and pain management physicians, nurse practitioners, psychiatrists, dentists, and so forth. So the scope of the guidelines was to look primarily at primary care physicians. And we had what was somewhat of an arbitrary and capricious designation that individuals should not be receiving dosages of greater than 90 morphine milligram equivalents per day. And there were some caveats built into that about who qualified for that. There were some data to support 90 that statistically speaking, individuals getting higher dosages in a morphine milligram equivalent basis were more subject to respiratory depression, to morbidity and mortality when we exceeded the 90 MME per day dosing guidelines. And so what happened was, based upon the 2016 recommendations, there was a lot of scrutiny upon physicians. If you were prescribing 100 or 150 or 200 MMEs, you could be subject to disciplinary action. In fact, the CDC recognized this, and the CDC recognized that the weaponization of these guidelines was not the intent. The intent was to be used as a parameter, as a barometer, as a framework for making clinical decisions, but not to exclude physician judgment. Unfortunately, several regulatory agencies took it to the extreme, to the detriment of physician practices, to the detriment of patients who required pain management using controlled substances. And so the CDC, in their second iteration of these guidelines, did recruit the help of 23 physicians to look at what would be a more approachable type of guideline. They also recruited patient subjects who were allowed to go in person and weigh in on their experiences. And they subsequently have made major modification to the 2016 guidelines. In fact, if you look at this very quietly published report from 2018, so shortly after the guidelines were dispensed, it came to our attention that the CDC realized, and they admitted, that they had significantly inflated opioid deaths related to prescriptions. In point of fact, they had taken patients who had died, who may have been consuming prescription opioids, but had neglected to account for the volume and the quantity of outside street drugs that were also conflating these data, meaning individuals who were either getting prescriptions but buying street drugs, or trading their prescriptions, diverting medications, and so forth. And it came to the attention of the CDC that these statistics, upon which they had based the original guidelines, ought to be seriously reconsidered, that the overdose deaths from physician prescribing was not the foundation for the opioid epidemic. They realized that the 2016 guidelines often did not fit clinical scenarios. They were encouraged to listen to actual patients. They brought together more than 23 physician specialists from a wide swath of medical practices, and they relied upon peer-reviewed literature for making formal recommendations, of which there are 12. There are actually 15, but I've summarized for your edification and for your benefit the 12 most important CDC guidelines as of November 4th, 2022, and you need to be apprised of this. This is critically important for each of you who practices pain medicine, where opioids or other controlled substances may be involved to manage your unique practice and manage your unique patients. So the policies purportedly drawn from the 2016 CDC opioid prescribing guidelines were notably inconsistent with the intent. And the CDC recognized that certain agencies, certain oversight groups had become overzealous and overly pedantic about looking at the 90 morphine milligram equivalents per day, and they wanted to change that. They wanted to set the record straight. And they have gone, according to the CDC, that certain oversight agencies had gone well beyond the clinical recommendations of the 2016 guidelines. They also recognized, again, that primary care physicians constituted approximately 37% of all opioid prescription writers, pain medicine clinicians about 9%, dentists 8.6%, orthopedic surgeons, family medicine clinicians as well. But by and large, that primary care physicians were primarily prescribing more than a third of all the opioid prescriptions in the entire country. They also recognized that the pain management specialist was not the focus of this clinical practice guideline, and they gave kudos to the fact that pain management specialists often have extensive training and expertise in pain management that other clinicians do not possess, and therefore they might treat more complex cases and clinical situations that are less prevalent and not well addressed by available evidence. And therefore they gave some latitude to the discretionary prescribing habits of pain management specialists. That's very good news for those of us who practice in the domain and the realm of pain management. They did nod to the fact that we have a unique set of skills, education, experience, training that exceeds the general practitioner. But they wanted to point out that there is no real hard, firm data for long-term effectiveness of opioids. And that's true. We all know that. Every one of us who prescribes opioids know that we have alternative strategies that could potentially be useful to our patients. They pointed out in these new guidelines that opioid therapy is associated with similar or even sometimes decreased effectiveness for pain compared to standard non-steroidal anti-inflammatory drugs, and that that's been studied extensively in the literature. They also pointed out that it was important that we consider discontinuing opioids, but patients who had been on opioids for extended periods of time could often not be liberated from the beneficial effects of narcotics or from opioids. It's a challenge. And that was basically information that they gleaned from discussing this topic with a large series of patients who had volunteered to contribute their opinions to the new 2022 CDC guidelines. They also pointed out that there were 4 general areas for these new recommendations, and those areas are as follows. 1, the physician should determine whether or not to initiate opioids for pain. Under what circumstances was that appropriate? The physician should also select opioids and determine dosages for both initiation as well as perpetuation of opioid use for the management of chronic pain. The physician should also decide the duration of the initial opioid prescribing and conducting follow-ups on a periodic basis, and they set the parameters upon which their expectations were for this process. And of course, very importantly, and this, it behooves all of us to conduct ourselves as such, assess risk, addressing the potential for harms associated with opioid use. Now, we all know that there are 6 risks attendant to the use of all opioids, and that includes things like nausea, vomiting, itching, or pruritus, respiratory depression, of course, being the bane of opioid use, but even things like urinary retention and constipation. They expected that every physician, every clinician, nurse practitioner who dispenses opioids would discuss these with any patient subject who might be a candidate for receiving an opioid prescription. So what was the first of the 12 recommendations? The first of the 12 recommendations were that physicians and prescribers ought to recognize and discuss with patients that non-opioid therapies are at least as effective as opioids for many common types of acute pain. By acute, we're talking about pain having a duration of less than 3 months from the initiating factor that led to that pain. And clinicians should maximize use of both non-pharmacological as well as pharmacological non-opioid therapies. So NSAIDs, for example, should be the mainstays of initiation. Acetaminophen should be the mainstays of initiation. Muscle relaxers, things in the gabapentinoid family, all of these, and local anesthetics, of course, which are underutilized. Local anesthetics, NSAIDs, gabapentin-related type drugs, all of these things should be considered as the foundation for acute pain, meaning a pain of less than 3 months duration. Non-opioid therapies are preferred for both subacute and chronic pain. So not just for acute pain, but for pain that persists greater than 3 months from its initiation. And clinicians are urged to maximize the use of non-pharmacological and non-opioid pharmacological therapies, as well as working with patients. So this again came out of as a consequence of soliciting patient input into this process. The CDC recognized that physicians and nurse practitioners who prescribe should work with patients to establish treatment goals for pain and functionality. So not just the simple 0 to 10 pain scale. We're not just looking at the improvement of a patient's subjective reporting of pain, but also are they functionally doing more when they're utilizing these medications. And in every case when I prescribe opioids, I document in the patient record not only what the pain level is without opioids as well as with opioids, but what fundamentally can the patient do differently when they're using these medications to manage their chronic pain conditions. Are they now able to walk further, carry a load to a greater extent, conduct themselves in the workplace if they're using these chemicals appropriately and still having employment? Are they able to engage in their social activities and their activities with their families, for example? All of this is documented in my patient record. The third recommendation, which is very important, is that when you're starting opioid therapy, whether it's acute pain, less than 3 months, subacute or chronic pain, greater than 3 months, you should use short-acting, immediate release opioids. Things like hydrocodone acetaminophen, things like hydromorphone, with or without an additive to it. Things like oxycodone with acetaminophen or without, but short-acting immediate release opioids, not extended release or long-acting drugs. So that should be the initiation, with the caveat being that there's an exit strategy for limiting the patient's exposure longer term to these immediate release opioids. Prescribing the lowest effective dosage. So if somebody comes in reporting pain of a moderate to severe level, and by moderate pain, we're talking about 4 to 7 out of 10 on the numeric rating scale. Severe pain, we're talking about 8, 9, or 10 out of 10 on this numeric rating scale. You should prescribe the lowest effective dosage. And so it's important. The patient who sees you for the first time and says that they've got some low back pain with a radicular component rated 7 out of 10, it's not prudent to then turn to that patient and say, well, here's 240 Norco tablets, or here's 240 Percocet tablets, and I expect you to take these 10 milligrams every 4 hours. That's not appropriate. Start with the lowest effective dosage, even if that means bringing the patient back within 2 weeks for a careful reevaluation as to the efficacy of the lowest effective dosage, meaning that you leave it up to the follow-up evaluation to determine the efficacy, not just in terms of pain control, but also in terms of improvement in functionality. Recommendation 5 were that clinicians should optimize other therapies, and that includes non-pharmacological therapies, sometimes interventional pain management therapies, sometimes physical therapy modalities, even including things like chiropractic care, at-home exercises. All these other alternative and competing strategies ought to be implemented and pursued with the clinician on behalf of the patient, and then work closely with the patient to gradually taper or lower dosages if warranted. So starting off with short-acting, immediate release chemicals, and then looking for strategies to take the patient away from opioids at the earliest possible convenience. Recommendation number 6, physicians or clinicians should prescribe no greater quantity than needed for the expected duration of pain. And that's important because you need to have a clinical acumen to understand the usual duration of pain, let's say from an acutely ruptured disc, or pain from some type of traumatic event, from some motor vehicle accident or some workplace injury, or from some type of condition which occurs following a medical illness or some type of calamity in the home. You should have an exit strategy, and you should prescribe no greater quantity or no greater period of time than the expectation is. And these expectations can be found in standard reference books. We know, for example, that most pain from an acutely ruptured disc, if it's not a surgical disc, if it's not a disc that requires interventional therapy, should persist for no more than 6 weeks. And those are the types of decision-making parameters that the CDC expects all prescribing clinicians to understand. Recommendation 7, you need to evaluate the benefits and risks within the first 4 weeks of initiating therapy. That means that it's critically important to make a reassessment. You don't see a patient with an acute or subacute pain problem, prescribe opioids, and then indicate to them to return in 90 days. That's not the intent of the CDC recommendation. Is to see patients early on after the initiation of therapy and provide a framework for whether or not perpetuating that therapy is clinically indicated. If it's clinically indicated and you've done your evaluations, you've done your urinary toxicology monitoring, you've checked your prescription drug monitoring program within your state or respective jurisdiction, and the patient seems reliable, the patient does not show any signs of impairment or intoxication, and the patient continues to have moderate to severe pain, maybe, possibly under those circumstances, you can consider ongoing use of opioids within restricted use. Recommendation 8 is to mitigate risk after evaluating risk for harm related to opioids, not just the known consequences of opioids, meaning nausea, vomiting, itching, urinary retention, constipation, respiratory depression, but also social risks, risks to the patient's employment, risks to the patient's relationships, evaluating risks, mitigating the risks, and also offering naloxone. Now, this was not part of the first recommendations or guidelines of 2016. This is a really new phenomenon, and naloxone has become prevalent everywhere. The police are carrying it, the fire people are carrying it. There are dispensation areas in certain pharmacies for procuring naloxone. Naloxone has become a very important staple in the management armamentarium of clinicians who are prescribing and dispensing opioids. It's important to discuss the use of naloxone with the patient and their family members if they may be elderly or if there's a language barrier to mitigate the risks of opioid-related consequences. Recommendation 9 is to consider the patient's history of controlled substances and to use the state's prescription drug monitoring program, which is now found in virtually all states of the United States of America. Before it was 40 states, then 48. Excuse me. To my understanding now, there's an implementation of a prescription drug monitoring program in each state. And so if you're initiating this, it's important to review the PMP in your state to make clinical decisions based upon what is noted, who's prescribing what, in what quantities. Have there been early refills? Are there multiple prescribers? This is a safety factor for the patient and for yourself, and has become paramount to protecting yourself and protecting your practice. Recommendation 10 involves toxicology testing, and it behooves you as well to engage in a periodic process of evaluating primarily urine, but of course there are other ways. There are blood toxicology, hair, nails, fingernails. There's ways to assess toxicology, the most commonly being urine toxicology, of course, and to document the results. It's not sufficient to obtain a specimen, to have some aberrant finding, which is noted on a printout, and for you as the clinician to ignore it. If there is an aberrant process or finding, you must have protocols in your office for how to contend with that. Do you have a zero tolerance policy? Do you have a one strike tolerance policy? All of these things should be built into policies in your respective practice, and you must adhere to them. You can't give patient A 4 chances and patient B 0 chances. You have to have a protocol and a policy which is assures strict compliance both amongst your patients and your staff when dealing with aberrant results on toxicology. Recommendation 11, obviously we've known for some time of the severe synergistic respiratory depressant effects of benzodiazepines primarily, but there are other chemicals as well that can lead to augmentation of the respiratory depressant effects of opioids. We should use particular caution when prescribing opioids with benzos. Now, it doesn't say that it's prohibited to do so, but you must factor in the risks and discuss the risks with your patient and document the risks and document any behavioral or objective findings of your patient being, again, sedated, slurring speech, looking intoxicated or impaired. This has to be documented in your medical chart. Recommendation 12, the final recommendation from the new guidelines of November 4th, 2022, from the Center for Disease Control, clinicians should offer or arrange treatment for patients who have opioid use disorder. Now, it doesn't tell you not to prescribe opioids for a recovering addict. It doesn't tell you to limit opioids to somebody who's had a history, possibly a remote history of addiction or opioid use disorder, but you must document it. You must document it. You must have the appropriate resources in place for support and know where to turn if the patient shows aberrant behavior, knowing what the risk factors are and the high likelihood of there being a possibility, at least, for a rebound effect or a relapse effect, and because of increased risks of resuming drug use, overdose, and death. And therefore, you must factor this in. They don't expect you, the CDC, nor the DEA for that matter, to be an addictionologist, but to have the ability to reach out and to contact support people and to make a referral when indicated, and to appropriately monitor your patients who've had such a history. Now, some entities going back to the 2016 guidelines, including orthopedic surgeons, including vascular surgeons and general surgeons, actually found that there were procedure-specific opioid guidelines that they could utilize based upon the 2016 recommendations. And here's a nice paper from 2020 in the Journal of Bone and Joint Surgery. So it's by orthopedic surgeons, that showed that following certain guidelines that orthopedic surgeons themselves had constructed, that there was almost a 40% reduction in opioid use in the post guideline, meaning after 2016 period. So the orthopods got together. They realized that physicians were being scrutinized. They realized that there were consequences to opioid prescribing. They came up with a list of commonly performed orthopedic surgical procedures, including things like ORIF, including joint replacement surgery, including shoulder, elbow, knee, hip, ankle type of surgery. And they came up with certain guidelines about what the appropriate effective prescribing ought to look like. And they were able to reduce across the country opioid prescribing by about 40%. Impact of opioid prescribed guidelines on postoperative spine surgery now also found a substantial reduction by about 47% in opioid writing when guidelines were followed for spine surgery. So some of the specialists had undertaken in their societies and in their groups, based on the 2016 guidelines, protocols and practices aimed at reducing patients' exposures to opioids. And it's been quite effective across the country for orthopedic and spine surgery. Now, we know that there's been legislation that has followed opioid prescribing. We know that there have been some grave consequences to clinicians, whether they're physicians or nurse practitioners, dentists, for prescribing. And each state looks at this in a unique fashion, despite the fact that the DEA is a federal agency. Each state takes legislation into advisement or under advisement, and they have definitions. Florida was among the states which was the most aggressive in pursuing legislation to carefully regulate who can prescribe and in what quantities and for what circumstances. They made definitions. This is important. Each state, including the state that you practice in, has their own unique set of definitions, guidelines, and mandates, including continuing medical education for individuals who will ultimately become or who are prescribers of controlled substances. It behooves you to look at your unique state website to determine what the parameters and the expectations are if you undertake to become a prescriber of controlled substances, because if you are not in compliance with your unique state guidelines, you can be subject to disciplinary action. Now, what is the current state of opioid prescribing according to the DEA? With action against physicians, this was published in the journal Pain Physician, which is the parent journal for the American Society of Interventional Pain Physicians. A nice review article. It looked at data over a 13-year period with an average finding of about 18 prosecutions per year in the year 2017. And what they found were some of the common features of who was being prosecuted by the Drug Enforcement Administration or agency. And they found that having a DO, an osteopathic degree, versus an MD degree, an allopathic degree, could be associated with higher risks of prosecution. If you were a male prescriber versus being a female prescriber, that could be associated with a higher risk of being prosecuted by the DEA. If you were not in a university practice or a hospital-based practice but were in private practice, you could be the subject to a higher risk for prosecution. If you did not have your board certification or were not up to date with your board certification, that could potentially subject you to a higher rate of prosecution. Certainly, with criminal types of cases, possession with intent to distribute was the highest or the most prevalent, including up to 52.3% of charges. So if the DEA or if there are reports from patients or from the community that suspects that you're a pill mill or a drug pusher, that's a big time problem. And that's a problem for which there is no latitude and there is no wiggle room, as they say. And so there was also, for some reason, a higher rate of DEA action taken for international medical graduates than there was for those who were trained domestically, stateside here. And for some reason, it appears that there was a higher likelihood of being either targeted or perhaps stepping over the line for international medical graduates. So those are the features of what tended to draw the attention of the Drug Enforcement Administration: DO, male, private practice, possession with intent to distribute, and for international medical graduates. Now, how has legislation and have the original guidelines worked? We certainly don't know the impact of the November 4th, 2022 guidelines. It's too new. They've only been implemented for the last 2 months. And we don't know whether the recommendations are being adhered to. In fact, most clinicians probably are only not acutely aware of the fact of their existence. We all became snake bitten. We all became hyper acute to the fact that these guidelines and the 90 morphine milligram equivalents came into effect in 2016. We did so because of what we found in the lay press and what we found in the oversight agencies. But have the original guidelines been useful? Did they work at all? Well, clearly, according to the Institute for Human Data Science study, there was a huge decline in opioid prescription writing up to the year 2017. So the guidelines came in 2016. And by 2017, there were 23.3 billion fewer morphine milligram equivalents dispensed to patients on a volume basis. That was a 16.1% reduction. And then later it was found a 22% decrease in prescriptions nationally between 2017 and 2016. And it was felt, according to the American Medical Association Opioid Task Force by Dr. Harris, it was felt that this reflected the fact that physicians and other healthcare professionals were increasingly judicious when prescribing opioids. So even though the 2016 guidelines might have been considered draconian, overly restrictive, and based on arbitrary and capricious data, nevertheless, physicians did take notice and did alter their prescribing habits. And it's important to do so because of the fact that the opioid use disorder is an extraordinarily expensive prospect, not just for the individual patient, not just for clinicians, not just for medical practices, but to the country as a whole. In fact, the cost for the opioid use disorder, as well as fatal opioid overdoses in 2017, so 6 years ago, were estimated to be over $1 trillion. It's an unfathomable amount of money, not billions, not millions, but $1.02 trillion. And obviously, it's an extraordinary public health problem, but it's also an extraordinary economic issue and problem in terms of lost wages, absenteeism in the workplace, as well as the death and destruction associated with opioid overdose. Now, are clinicians using urine drug monitoring? And we've discussed that. That's one of the newer parts of the updated November 4th, 2022 CDC guidelines. The expectation is that there's some form of monitoring patients to determine not only the suitability of that patient for receiving opioids, are they being using the medication as prescribed, both in quantities as well as frequency, or are they receiving outside medications? Are they diverting their medications for street drugs? Are they receiving prescriptions of alternative chemicals which they've never disclosed to you? Are they using marijuana? And if so, does your state, for example, have mandates against the use of medical marijuana? And we all know, of course, that marijuana is not permitted due to federal regulations. It's still considered a controlled substance. Your DEA license is a federal license, not a state granted license, although some states, including the state of Illinois, where I'm sitting right now, does have a state controlled substance license. But the DEA, the Drug Enforcement Agency, does consider it your license to be in adherence with federal and not local mandates. And so it was found by this nice paper published in Pain Physician in 2021 that less than 50% of practices were actually using urine drug monitoring, and that is anticipated to change. As I stated, the new guidelines have an expectation that urine drug monitoring will be part of the practice for assessing compliance of patients who are receiving controlled substances. And we know that there are a lot of practices which do monitor patients. There were more than 2 million drug testing claims reported over a 4-year period from 2016 to 2020. And that, however, a lot of reasons that clinicians have turned away from urine drug monitoring is that recently there's been a 70.5% reduction in payment to physicians' offices for conducting these tests. So whereas it used to be extremely lucrative to conduct urine drug toxicology monitoring, some laboratories would charge $1,500 for a single 4-specimen, 4-chemical analysis. Now the reimbursements have shrunk, as would be expected when the government started to take stock of the fact that there was some gamesmanship involved with urine toxicology monitoring, respectfully, of course. But the reimbursements have shrunk, and so some practices have now turned away from urine drug toxicology monitoring. The CDC expectation is, however, that this will continue to be part of the practice if you're in the practice of dispensing controlled substances. I want to just go through a few more concepts, if you will, I think are important if you're going to be a prescriber of controlled substances and opioids. You should understand definitions, things like dependency and things like addiction and things like withdrawal. But you should also understand definitions like chemical coping, which is a behavioral disorder which bears a resemblance to addiction but is not addiction. It's also not dependency and habituation. It's because the use of opioids is inappropriately used to manage stress, sleep disorders, bad relationships, etc. Chemical coping is something which you cannot prescribe opioids for. You cannot prescribe, it's outside of legitimate medical purposes. And I highly recommend that if you're in the practice of prescribing opioids to your patients, that you utilize a test, one test that is probably best patient administered. I like the opioid risk tool. There's only 5 items in the examination. It's patient-centered. Patients complete a checklist. I'll discuss it with you in just a moment, but there are others. The screener and opioid assessment for patients with pain, also known as SOAP. The DIAR, that's called Diagnosis, Intractability, Risk, and Efficacy Score. PMQ, COM, PD, UQ, the CAGE, AID. All of these are examinations which you can either subscribe to or download, in some cases for free. But I highly recommend that these opioid risk assessments are part of your practice, at least at the initiation of therapy for patients who are new to you. If they're legacy patients and you've had them for some time, you probably want to utilize an opioid risk assessment tool periodically, meaning every 12 to 18 months, just to determine whether the patient's circumstances have changed. Now, how do we utilize these? Well, let's look at the ORT, the opioid risk assessment or opioid risk tool. Simple 5-question questionnaire. The patient does it. They sit down in your office while they're registering it prior to opioid therapy, and then you can score the patient as being at high risk, low risk, or moderate risk. And it's very useful because obviously the risk factors may change over time. And if you are prescribing to patients who are at high risk, you need to make an assessment of your practice parameters and your practice habits. So the opioid risk tool includes things like a family history of alcohol, illegal drugs, or prescription drugs, and the examination is rated differently if the patient is female or male. Personal history of substance abuse, age between 16 and 45, which is really the red flag age for addiction and opioid use disorder, and you need to study this. History of pre-adolescent sexual abuse, very prevalent amongst females, not so much for males, although that is changing, and that can be rated as high in terms of the possibility of opioid use if there's a strong history of that. And psychological diseases, again, rated for ADD, OCD, bipolar, schizophrenia, we'll talk about that momentarily, or depression, and again, rated whether an individual is male or female. SOAP, another very useful tool, screener and opioid assessment for patients with pain. It's usually self-administered, again, can be completed in the waiting area or the examination room, can be completed as part of the interview when your physician extender, your nurse practitioner, or your patient service rep goes out to interview the patient. And you should have a completed and scored SOAP while making your decisions related to controlled substances. So these are important concepts that we previously didn't take into stock much going back 10, 15, 20 years ago. It's important to have some type of opioid risk assessment to justify your decision making if you're ever audited, or if a patient ever sustains a complication and decides to institute a legal action against yourself or your practice. You should have the capability to go back and say, well, I conducted an opioid risk assessment using X, Y, or Z tools, and the patient was felt to fall within the parameters of acceptable risk. It's very important, at least during initiation. Now, what are the kinds of things that we ought to be considering when we are both initiating and then utilizing controlled substances, primarily opioids, for long-term use? And I will tell you that what is coming to be an undeniable factor in managing chronic pain is the use of buprenorphine. Buprenorphine is an extraordinarily important drug which has been around for more than 40 years, since 1981. It's an antagonist at the GABA receptor, and it's only a partial agonist at the mu receptor, but it does bind very tightly to the mu receptor. In fact, more so than morphine, more so than heroin, more so than fentanyl. It has a very slow dissociation from the receptor with a very milder type of withdrawal phenomenon. So it's useful. It's a potent analgesic. It's not associated with drug liking from individuals with a history of opioid misuse or addiction. And it's not a drug of abuse to the same extent as, for example, morphine or oxycodone or fentanyl would be considered. In double-blind studies, buprenorphine injection produced very little good effect with subjects who had previously had a history of substance misuse. In fact, there were increased ratings of it being a bad drug. So if you're going to take the recovering addict and put them like a taste test, like Coke, Pepsi, Diet Coke, RC Cola, and say, tell me your favorite drink here, they're not going to pick buprenorphine as their favorite. It's never going to be the drug which is selected as tweaking the pleasure center in the brain associated with opioid use, but it is a very potent and very effective opioid for managing legitimate pain. It's just not going to be liked to the extent that other chemicals might be. It's been around since at least 1981. Buprenorphine is the injectable product indicated for moderate to severe pain. In fact, there are only 3 formulations of buprenorphine approved by the FDA for moderate to severe pain, and that's Buprenorphine, the injectable, Butrans patch, which has now been around for some 12, 13 years or so, and Belbuca, which has been around for about 6 years. Those are the 3 preparations of buprenorphine which have been approved for use for moderate to severe pain. In the early part of my career, I studied Buprenorphine as an adjunct to local anesthetics, published several papers on this phenomenon, adding buprenorphine to local anesthetics for brachial plexus block or for sciatic nerve block, for example, with great success. So it's a very powerful co-analgesic to local anesthetics, and that's the primary use, although some people continue to use the intravenous or intramuscular formulation of buprenorphine for moderate to severe pain. Butrans patch, very useful preparation, comes in multiple dosing strengths, 5, 10, 15, 20 micrograms per hour. It's a 7-day patch, so it's great ease of application because it can be, for example, utilized once a week to manage pain without the requirement to have to constantly change the patch for patients who are experiencing pain, as the fentanyl patch would be, which is a 72-hour patch. The Butrans patch, being once every 7 days, is more likely to be tolerated. I have seen patients who've had adverse reactions to their skin, however, from using buprenorphine patch, and so it's important to indicate to the patient to rotate the location of where the patch is placed. And of course, Belbuca, a very interesting buccal strip, also comes in multiple dosing strengths and formulation, and I have found that to be useful for patients with moderate to severe pain, again, without the likelihood of engendering a significant withdrawal reaction. So we know that it's a partial mu receptor. There's a decreased ability for abuse when we use buprenorphine products, very low risk of physical dependence and analgesic tolerance when we use this chemical. And compared to a full mu receptor agonist, for example, when patients are utilizing drugs like fentanyl, drugs like oxycodone, hydrocodone, hydromorphone, much less likely to engender a tolerance phenomenon for those patients. Now, the other benefit of buprenorphine, according to the DEA classification, is that it's a Schedule III type drug. There's less abuse potential than Schedule I, which have no legitimate medical purposes per se, drugs like heroin, PCP, marijuana, and for those for which we are presently prescribing that do have legitimate medical purposes, Schedule II, drugs like oxycodone, hydrocodone, hydromorphone, morphine, and fentanyl, and has a very low risk for moderate risk of physical dependence. Also, if you're going to be prescribing, you need to have the ability to understand and elucidate whether your patients have psychiatric comorbidities, including things like substance use disorders. So even though the expectation of CDC and DEA is not that you are a psychiatrist, not that you're a licensed clinical psychologist, you must be able to independently observe patients and make independent determinations as to what these comorbidities might be that could be influential in your determination of suitability of patients for prescribing opioids. You must make an assessment of things like bipolar disorder. Why? Because we know that bipolar disorder has a very high likelihood, a high prevalence of being associated with substance use disorder, up to 56% of individuals, including a 33% with lifetime alcohol abuse and a 20% of lifetime cocaine dependence. So it's important to determine if your patient has a bipolar disorder, how they're being treated and by whom, and whether or not you still wish to initiate or perpetuate the use of opioids. Depression is found in a relatively small but not negligible percentage of individuals who have substance use disorders. So it's important to comprehend, to determine whether the patient has depression, whether the depression is being treated. Is it being treated with psychoanalytical protocols or pharmacological protocols? Do those protocols influence your decision-making on the dispensation of opioids? ADHD and substance use disorders. Again, 52% of adults with ADHD will have a lifetime substance use disorder. It's really astronomical. And in teenagers, the comorbid conduct disorder and bipolars mediate future substance abuse. It's very important to determine and to evaluate individuals who have ADHD, make a determination independently of their pain, whether or not they're a legitimate candidate for the use of controlled substance. Access to disorders and substance use disorders. There's a 60% comorbidity of personality disorders, including antisocial personality. 84% comorbidity of antisocial personality disorder with a substance use disorder. It's extraordinarily important to be very carefully considerate and scrutinize patients who've had or carry either a present or former diagnosis of antisocial personality disorder before determining their suitability for the dispensation of opioids. Anxiety disorders, again, any anxiety disorder, the occurrence of substance use disorder is about 25%. PTSD, more than 50% of men and 28% of females who have PTSD will be subject to substance use disorder, and a panic disorder, also a high prevalence or a high incidence of substance use disorder. Schizophrenics, 47% lifetime substance use disorder. Approximately 80% of schizophrenics are known to be nicotine dependent, and we know that there's a strong correlation and strong relationship between dependency on tobacco products and nicotine, with ultimately derivation of a substance use disorder. Very important to determine if your patient has a present or current history of schizophrenia before determining their suitability to prescribe opiates. So what are my final recommendations for this talk? And I hope you've taken something home with you about the new November 4th, 2022 CDC guidelines for the use of opioids, the reliable and rational and responsible use of opioids and controlled substances for your patients. Use the prescription drug monitoring program. That's number one. Utilize urine drug toxicologies on your patients at initiation and periodically, and certainly more frequently if there are concerning behaviors Remember that substance use disorder and addiction are behavioral disorders, so you must evaluate your patient. Don't just have patients randomly come to the front desk to retrieve prescriptions that are pre-filled by your office staff and that you have signed. Evaluate your patient. Make a notation in your patient's chart as to their suitability from a behavioral perspective for the ongoing dispensation of controlled substances. Do not prescribe opioids at the very first visit. And I'll show you a tragic outcome to that process, but it's very important to stand by that rule. Don't use benzodiazepines except under severely limited circumstances and then with increased scrutiny of your patients. Always educate your patients as to the potential for synergistic respiratory depression when they mix benzodiazepine with opioids. Screen your patients. If you're getting a referral from an outside source of a patient who's been discharged from 5 pain centers over the last 12 months, that's probably not a patient that you should be intent on pursuing to have in your practice. Use 90 MME. This is an old slide. That was something which the 2016 guidelines recommended, and it was only a recommendation. Unfortunately, it was weaponized by many oversight agencies. The 90 morphine milligram equivalent number, which was arbitrary and capricious, although supported by some data of morbidity and mortality, has now been dispensed with. The new guidelines do not specify an upper limit of morphine milligram equivalent, so that's very important. Ask about withdrawal of your patients. Ask about alcohol. Use the CAGE test. Educate your patients regarding the potential for diversion of their chemicals from family members, from visitors, from transients. Make sure that patients understand the essential nature and responsible use of medications and where to safeguard them. Use psychotherapy in a highly structured approach for your patients, even though the expectation is that you are not a psychiatrist or psychotherapist, and use the best approach to your patients. The minimal amount of medication for the minimal amount of time while reassessing them on an ongoing habitual basis. Use buprenorphine, maybe tapentadol, avoid methadone. These are my final recommendations. Also, remember that despite best practices, bad things can happen. This is the tragic story of Dr. Todd Graham, who was practicing down in South Bend, Indiana. He was a physician in his early 60s. He was a family medicine doctor, but with a pain medicine background. He worked in a large orthopedic group. He had a patient referred to him by one of his orthopedic colleagues, and the patient came into his practice one day with her husband, and the patient was demanding the use of opioids, and Dr. Graham did his thorough evaluation of the patient. He did a thorough neurological and physiological evaluation, and he found that the patient was not a great candidate for the use of opioids. She had a history, some 10 years of using opioids, but the husband was very demanding and said, Dr. Graham, you must give us hydroxycodone or she'll have a withdrawal. And Dr. Graham said, well, it's the practice protocol and our policy not to dispense opioids in the very first visit. We'll take this under consideration or under advisement. And the husband became livid and waited for Dr. Graham outside in the parking lot when Dr. Graham left for the day. The husband confronted Dr. Graham. There was a brief argument, and the husband pulled out a handgun, shot Dr. Graham twice in the head, killing him, and also then turned the weapon on himself and committed suicide. So physicians are casualties of the opioid epidemic. We're casualties of addiction. We're casualties of substance use disorder. Oversight agencies are leaning on us continually, but make no mistake about it. The new November 4th, 2022 guidelines are less restrictive by the CDC on the one hand, but they also demand more physicians on the other hand. The expectation is that we will be very reliable and responsible. We will take control of who we determine is a reasonable candidate for the dispensation of opioids, but we will monitor those patients, we will assess those patients periodically, and we will refer those patients out to the appropriate referral source if we have any concerns about any psychological overlay or any potential for harm to those patients. And so remember, the final message that I have for you is have an exit strategy. An exit strategy means that if you find that you're in trouble because your patient is either not compliant or appears to have aberrant behaviors or appears to be on the verge of some type of impairment, have an exit strategy for referral of that patient out. Consider behavioral counseling, consider medically supervised withdrawal. Make sure that you have plans for adjunctive therapy, including interventional pain therapy and physical modalities and non-narcotic medications where you can transition your patient away from narcotics to a non-narcotic adjunctive type of protocol. Also consider the use of things like intrathecal drug delivery systems or opioid pumps. I have several patients who were just chronically dependent upon opioids. The opioids did help them with their pain, and they were more functional with opioids, but I made a determination that rather than use oral transdermal types of formulations, we would go with a drug pump, an intrathecal drug delivery system. If you have the capacity in your practice to do that or offer that to your patient, it's a great alternative to continuing to perpetuate legacy patients who've had a long relationship with you, who may have reached the endpoint of the responsible use of opioids in terms of functionality. They may have found that these medications are no longer providing the same benefit to them. Consider an intrathecal drug delivery system. Consider the use of opioid rotation. And when patients get worse despite the use of opioids, consider the possibility that they have the phenomenon of opioid-induced hyperalgesia, which is still a little bit controversial, a little bit poorly understood, but which appears to be a phenomenon that could influence patients' adverse responses to even augmenting the dose of opioids. And with that, I've taken about an hour of your time, and I appreciate your attention to this vital matter. Go back and pull up on a search engine the 2022 November 4th CDC updated guidelines for the appropriate management of patients using controlled substances. It will save you a great deal of worry, consternation, and possibly oversight to understand, implement, utilize these guidelines. They're certainly more favorable to us as practitioners and dispensers now than what I perceived the 2016 guidelines to be. And that's a debt of gratitude to the CDC for recognizing that their statistics were wrong in many cases related to overdose deaths and controlled substances, and that they ought to implement a working group made up of primarily clinicians, but also listen to patients. They've done that now. And I think that this is a much better pill to swallow, no pun intended, for those of us who prescribe controlled substances in terms of managing acute, subacute, and chronic pain for our patients. Thank you. Have a wonderful rest of your meeting. Thank you for participating in the Society for Pain Practice Management. Goodbye.
Thank you, Dr. Candido. That was a really thorough and comprehensive overview, and I appreciate you having such an excellent overview of the new guidelines.
Thank you. You're very welcome.
This concludes this portion of the lecture.